So welcome everyone, my name is Randy Johnson. I'm just going to do a quick introduction for our candidate for today. So we have presenting in seminar Brett Beaulieu-Jones, who's our current instructor at Harvard Medical School, and I think a friend of the family, so to speak, in the Center for Health AI, as he previously trained with our very own Casey Green. And I know I've heard, Brett, that you have an Emmy, and perhaps is it on the shelf behind you? I can't tell.
No, it's out in the other room, but
okay, it needs a more prominent place, perhaps. So we'd like to welcome him. He's a faculty candidate here to give a seminar today. The title's here on the screen: Generating Robust Insights of Disease Heterogeneity and Patient Outcomes with Real-World Data and Machine Learning. So I think with that, Brett, you're welcome if you would like to add anything else to your introduction, but go ahead and take it away.
Sure. Thank you very much for the chance to speak and for the introduction. Let's see. There we go. I have a few disclosures to make. So both in terms of funding, a variety of grant funding for sponsored research projects. So particularly of note, I'll talk about projects from that are funded by both UCB and Sanofi today, and I'll try to make sure that I call out those sections so that it's clear where the funding is coming from. I also have been involved in a number of startups. I don't currently hold equity in either Synconsight or Salutary, but still have some attachment there, to given they've both been acquired by outside companies. And then a variety of other consulting and other activities with venture capital and pharma companies. And I don't think that anything that I've done there will be relevant to anything that I present today, but I'll make sure that I call out the grant sponsors where appropriate. And so sort of my research really focuses on this idea that we are dealing with data and really trying to make use of real world data in useful ways. But we have to acknowledge that what we are trying to do here is to model biology, a very sort of complex system that sometimes we don't have a complete understanding of yet, using something that is an artifact of the healthcare process. And it's something that is a number of steps removed. So if we sort of just start thinking about it in terms of going on the pathway from biology to understanding that we may have actual measurements of a patient's state at a given point in time. This is an example of an EEG, but this would only be when a clinician ordered an EEG for that patient, and we'll have it in sort of a limited snapshot at that time. And so as we get even more removed to clinician actions and maybe notes around a procedure or something like that, again, there's further clinical decision-making leading here. That's a filter for the data before we end up with what we have to think of as a potentially biased and noisy data set. It can have all sorts of factors that lead to the final real world data that we actually work with. And so despite this, like many others, I really want to use these data to do useful things, both in terms of biomedical discovery, but also in terms of clinical decision support and actually giving information back to clinicians that can help them to be more effective. And so I really like to try to present it in this way to acknowledge the challenges that we face, to acknowledge that we're dealing with a potentially noisy and biased data set, and to really do these things, we need to, I think, account for the data generation mechanism. And so the main area that my work has had sort of a common thread and focused on throughout, all the way back to early PhD through my postdoc and now as an instructor, is to try to identify patient subpopulations that are more homogeneous so that we can do cleaner and more powerful biomarker association. And so this all comes from a central sort of hypothesis that if we see heterogeneous disease presentation or progression, there may be a differing etiology, and in that we include the environment that is actually causing somebody to present and progress in a particular way. And so I'll call this sort of precision phenotyping throughout, where we're trying to use real world data to find these populations where we can make things like biomarker association easier. And so this isn't really a foreign idea. This is actually a slide that I've used a number of times, even going back to my PhD dissertation, where we know diseases, sort of the definition of diseases evolve over time. We learn more about a particular condition, and we can subtype it, and oftentimes, particularly in this example with lung cancer, have different treatments for different subtypes of disease. Unfortunately, not everything is as easy to physically subtype or even sort of look at genetics to identify these subtypes and therefore have targeted therapies. We could think of something like MS, where most of the subtypes are defined by disease progression and the way that the patients actually present. And so those are the cases now where I want to move into to say, we've been able to do this in lung cancer effectively. Now let's start to apply this, particularly within neurology, to complex heterogeneous conditions. And so I'll break out the rest of the talk now after that background into 3 main sort of case studies or examples of projects that we've done. So the first will be really just looking at the methods of how we can deal with the fact that the data we have are artifacts of healthcare interaction, and certain approaches in terms of how we can trust things. And this is where sort of I brought in the part about robust insights, and so really understanding what is actually generating that insight. The second part will be sort of subpopulation identification within epilepsy, and the third will be some of work that we've done that was meant to support a clinical trial within Parkinson's. And so this is a figure that has become really popular in my postdoc advisor, Zach Kohane's group, as sort of an illustrative introduction to some of the healthcare dynamics and issues that we need to account for. Where in this figure, you may be able to sort of see this for yourself, but the key sort of finding that we really like to highlight is the fact that the patients who have a white blood cell count measured between midnight and 8 a.m. actually have a lower 3-year survival than patients who have abnormal, either low or high white blood cell counts. And so we really take this to say that the clinical decision-making process and treatment process is potentially very informative. And so the justification or reason that we've sort of settled on in terms of why this is that if a physician is concerned enough about a patient to potentially wake them up, or most likely wake them up for a white blood cell count in the middle of the night, it means they're concerned about that patient. So we're essentially seeing a measure of clinical intuition here. And these data can be generated in this way for many different reasons. And so some of the most obvious could be sort of patient access to healthcare, as well as clinical decision making. And we've seen this in some of our own work. We looked at sort of encounters and tried to predict the presence or absence of a particular lab test here. And so on the left, you'll see an AUC going up from sort of random performance to perfect performance for 138 labs and lab panels. And the real takeaway, obviously this is too small for you to see specifics, but for the vast majority of labs and lab panels, there's at least some signal in our ability to predict whether it will be present in a particular encounter or not. And so we can't treat these data as if they are missing completely at random, and we really need to sort of take this into account throughout the rest of our processes. You can't sort of just use a sort of basic imputation method and expect to see sort of downstream results that are appropriate, or do things like complete case analysis. And so we sort of followed this up and saw in a variety of different ways that even this process of potentially imputing the values or learning a representation of the data can be informative. And so in this, just to sort of touch on this, this was sort of at the time, a sort of throwaway figure that we got asked to add on to a paper that was mostly simulation-based and methods-based, and really got pushed by reviewers to include some real world data. And little did I know that it was going to sort of lead to a lot of my current work now. But in this, we have these 2 plots. There's no line separating them, but there are 2 separate plots where one is PCA of patients who are present in ALS clinical trials. So it's a heterogeneous set of 23 different ALS clinical trials. And we can sort of take the data and just look at the representation. So we can do a dimensionality reduction and plot these patients. And on the right, we have an autoencoder learned representation of these patients. And so without really trying to draw any conclusions. And at the time, we didn't have any neurology collaborators or really attempt to go too much further into this. We did see that sort of by chance and sort of with no supervision or sort of intent, we were able to start to group these patients in essentially a meaningful way, where particularly in a couple of the clusters, you can see that these patients have the shortest survival. And so all of this led us to start to ask questions about many of the machine learning models and sort of approaches to offer clinical decision support in practice. And so in 2019, there was a collaboration between researchers at UCSF, the University of Chicago, and Google, where they looked at over 200,000 patients with full EMR data access to predict common outcomes, most notably things like in-hospital mortality and readmission rates. And so when we saw this result, we first had some questions because the sort of expert extracted features passed into logistic regression do close to as well as the deep learning model that took immense computational time. So that was sort of the first takeaway. But the second was, even if we attribute and say that there's really good performance here, could these ever be helpful for individualized clinical decision making? And this is something that we really wanted to dive into to understand sort of the strengths and weaknesses of models. And so to do this, we really needed to think about what the models were learning from. And so I'll ask you to sort of bear with me through this for a second, because we've split it into two black and white groups where in reality it's much more of a spectrum with lots of gray areas in between. But for sort of an example case, and for the one that we actually will dive into for our analyses, I think it is fairly black and white. But we split the data into two categories. One being those that are clinician initiated. And so these are the data that are present in the EMR and are the result of a conscious clinical decision or action. So these are the things where a clinician is sort of explicitly ordering something that wouldn't sort of happen automatically, or every patient in the ICU has vital signs monitored. Instead, we're looking at sort of an explicit test where there's some thought process going into that decision making. And then the second are those data that are not clinician initiated. And so these are things where whether or not a clinician was there to make a particular decision would be generated anyways. And so these are things that are routine. So if somebody is coming to the ICU and getting vital signs monitored, that'd be a good example. But also things that actually represent the patient state, so the direct physiological measurements of that patient. And so for one example, we'll say that the presence of a particular lab test isn't always clinician initiated, because it could be either routine or decided to be ordered. But the results of that test are always non-clinician initiated. And so that's really the distinction of, are we modeling the clinical decision-making process, or are we modeling the patient state? And so what we wanted to ask was, could we actually learn from clinician-initiated data, and how well could we do without actually really trying to model the patient state? And so to do this, we used a very large data set of charges data, which aren't typically, or at least I haven't seen particularly widely used in research, but we can look at the line items that eventually lead to a bill for a hospital stay. And if you sort of look at this, you can see a variety of labs, procedures, but even things like room and board being kept here. And in some of the cases that we've looked at, things like the time that an OR was actually used for and charged for can end up being really informative. And so we had, because these can be de-identified and aggregated, an incredibly large data set to work from. So this is from the Premier Healthcare database, where they work in a number of quality improvement areas to offer software, and through that, their members contribute data back in a de-identified fashion. And so for these administrative charges data, there's almost 43 million multi-day inpatient admissions to work from. And an important thing to note is, even when you look at sort of thankfully rare outcomes such as mortality, you still have quite a large sample size and event set to actually look at and to predict from. And so we set out to ask if we could predict a number of the things that we had seen in the UCSF, University of Chicago, and Google collaboration. where we intentionally didn't want to innovate technically, whether on purpose or unintentionally. And so we tried to keep our representation very simple, because what we wanted to compare was the actual data type being used in the project. And so in this, we used a comparatively simple model that I won't spend too much time for time's sake today. But we, on one side, pass in static patient demographic vector or information. So that's things like age and gender, as well as sort of the way that somebody actually arrived at the hospital and any sort of other information prior to the hospital visit. And then we passed embeddings in, which are mathematical representations of events learned by training models in an unsupervised fashion on different orders of events that are, or charges in this case, that are occurring. And so we'd have a vector to represent each line item from that charges table. These can be merged in a deep neural network and used to predict a particular outcome. Again, I don't think that the methods in this particular example are really the important part of the message. And so I'll move quickly on to some of the results and some of the conclusions that we can draw from. So within this, we also had to acknowledge that we had several severe handicaps in our data set, despite the fact that it was much bigger. One, in the original paper, they only report the individual hospital's performance, but we don't have counts of events in each of the hospitals. So we compare against the higher performing hospital. And there's usually about a 0.02 or 0.03 difference for each of the outcomes. We're also averaging across almost 1,000 hospitals. So there are batch effects where we're dealing with heterogeneous data. The baseline method includes the first 24 hours of admission, where in our approach, we're only looking at the first day. And so what that means is if somebody arrives at the hospital at 10 p.m., we have 2 hours of data. And so there's a potential challenge here. And this is really due to the de-identified nature of the data, where we don't have it down to sort of the hour element. We only have sort of the day of service that it occurred. And so this was the sort of handicap that we had to put there. Additionally, the model that the Google group used, obviously given their sort of computational power, it's not surprising. But if we sort of did an evaluation to run it within AWS, and it was going to be at least 5 figures for comparison on sort of similar hardware. And so our model, which we know we've kept intentionally simple, it can be trained on a single GPU in less than 24 hours. And then obviously our data, we have much less per patient than sort of the baseline methods. And so when we do this, we saw that our model performed closer to the benchmark than we necessarily expected, especially when you consider this is the higher performing hospital, and sort of the lesser hospital, I think, was in like the 0.92 range for mortality. You can see it for things like length of stay as well. If you start thinking about sort of the less performant hospital, the confidence intervals can even start to overlap. And so we show sort of here in the dark red our model, in the blue is the baseline. And just to sort of really understand what the models are learning from, we also included, if we only have sort of up until the period of admission, so we have sort of patient demographic information and the way that they arrived at the hospital, whether they were sort of referred or brought in an ambulance and things like that, as well as only demographic information. So this is essentially learning from age and gender at that level. And so we could see that there's sort of a stepwise improvement in performance as we add more information. Additionally, because the data set is so loud and this is so large, and this is potentially the value of these types of data that are a little bit easier to aggregate across hospitals without as many privacy concerns, you can actually start to look at individual cohorts. And in some cases, where a myocardial infarction model outperforms the global model that we had built substantially, it may even actually perform better than the EMR-based model for that particular cohort, given sort of the relative performance differences that we see here. And so we intentionally chose sort of myocardial infarction for this example, because you could put somebody into a myocardial infarction cohort relatively quickly after arrival to the emergency department. And so this really sort of as a whole got us thinking about what these results mean, because we know that our models are really just looking over the clinician's shoulder and essentially cheating off them on the test. We're learning sort of the set of events that they do and able to predict a risk factor or a risk based off of that. And it sort of got us worried when we think about models that have similar performance may not actually be gaining any signal from the non-clinician initiated data. And we need to be, I think, careful when we see this and attempt to rely on it, because if we're sort of looking over the clinician's shoulder and able to do approximately as well, how can we sort of purport to help them when we're sort of following them around and sort of being a step behind them? And so I'll give an example of this, and which I think could actually present trouble and potentially lead to harm if we integrate these models and actually deploy them. So we've called this confusing feedback cycles. And so if we have a patient who comes in and it leads to a clinician thinking that they may have a pulmonary embolism, and because of this, they order a CT to look at, and through that imaging, they decide we don't see a pulmonary embolism there, and therefore this patient is lower risk. But they're still sort of concerned and aren't completely sure about what's going on with the patient. They open their chart because the clinician-initiated model hasn't actually analyzed the CT and it's only using the clinician's actions. It will still tell the clinician that the patient is high risk until the clinician takes other steps. And so if you are that clinician, you may be very confused about the fact that you just looked at this image, you didn't see anything to worry about, but the CDS in the EMR is still saying that somebody is high risk. And so you're left there sort of confused about why the model is telling you that this patient is potentially still high risk. And so at a broader scale, this gets us to thinking about how these models should be used. And so we think there's a potentially much more limited set of things that clinician-initiated models should be used for, or models that can't sort of do better than the clinician-initiated models, where they can be used for things like population health, to see what inpatient load and acuity of a particular floor looks like, or supply chain planning and risk adjustment for other analyses. And we could take this further and have started to really look at these as different sort of agents that represent things within the healthcare system. So we could say that the CI model is sort of learning clinical intuition. The NCI model, if we had a perfect one, would be a proxy for patient physiology. And we can compare that to the types of things that are typically deployed that include both types of data. And so this is something that a summer student of mine who is now continuing this project is working on to really dig into when these models disagree and what we can actually learn from. And I'll just give one sort of quick example of that as well. So if we go back to the pulmonary embolism example, and consider this idea that models may diverge and have different predictions, we can sort of move forward and potentially learn some interesting things. And so in this example, the CI model predicts that so say that sorry, there's a little bit of background noise. I don't know if someone can go on mute.
Leslie, I think we can hear you.
Michelle, would you mind just muting? I think it's Leslie. Would you just mute her screen with the little 3 dots? Yeah, thanks.
Okay, thanks. If we sort of take that same patient who had the potential pulmonary embolism and sort of the clinician sees and looks at the imaging and says there's no pulmonary embolism here, so he takes a number of actions after the fact. And so now the CI model has updated and saying this patient is low risk because the clinician has decided that there's no PE there. But we have a separate model, a new model that is trained to actually read the CT imaging. This model is predicting that the patient is high risk. So now we have divergence where the two models are predicting different things. And we think this is important because regardless of which model is right, we can potentially learn some really interesting things. It means either that the CT model is wrong and we found a hard image to read. And so now we have sort of an edge testing case that can be interesting to train future models on and to evaluate performance on. Or the physician missed something in the image, and we need to get a second check on that patient and a second opinion to see if there's something to be concerned about. Either way, we think that there's value in knowing when these models trained on two different types of data diverge. And so one last sort of aspect to this section that is outside of the work that we've done, but I think critical, and I feel sort of a moral responsibility to talk about these things when we're talking about predicting outcomes for patients and clinical decision support, is this idea that we have this assumption that accurate models of predicting patient outcomes will lead to, or accurate models of predicting future things for patients will actually lead to better patient outcomes. And so this is a group out of Yale who ran a study looking at acute kidney injury, where they didn't use any predictive analytics. They used national societal guidelines of when somebody either has acute kidney injury or is at high risk of it, to randomize patients and either show a clinical decision support alert or not. And that alert would allow the physicians to order an order set that would lead to sort of closer management, so essentially fluids management, or to actually add acute kidney injury as a problem. And so these are what we would assume are relatively non-invasive, benign interventions and things that are unlikely to ever lead to patient harm. And so they randomized whether this alert could be shown for a particular patient, so at the patient level, so true randomization, and it either would show or not. And this best practice advisory was then evaluated to see the outcome or the impact on patient outcomes. And what they actually found was that in the non-teaching suburban hospitals, the patients who were in the alert group had higher rates of mortality. This was sort of what I see as a fairly shocking finding, and one that if you have worked with clinical decision support tools, this is quite a large effect size as well. This is sort of the type of effect size that we would sort of dream about creating in the opposite direction with a new tool. So it's quite a profound effect. And so the takeaways are really twofold. So one, as they sort of state in the paper, we need to be doing randomization and true trials of even benign interventions and quality improvement programs. This is even sort of outside of some of the predictive analytics side of things, but it becomes even more important when we don't know or fully understand some of these more complex models. Additionally, we did a secondary analysis of the data from the study and found, obviously acknowledging that this is post hoc, we lose randomization, all of the sort of statistical challenges in doing something that way. But what it looks like is for some of the patients with complex comorbidities who have the alert shown in these hospitals, they have a higher rate of death. So it's those who have a complex or severe comorbidity. And so what we think is happening, again, this is purely a hypothesis at this point, is that these alerts are essentially screwing with clinical intuition and leading physicians to worry about acute kidney injury when previously they had a pretty good intuition of how to balance the risk of acute kidney injury versus CHF or some other major comorbidity that they were looking at. And so I just feel that this is a really important sort of component to a lot of the sort of modeling and statistical work that we do, that we have to follow up and actually look at the outcomes and impact. And so with that, I'll move to the second section, and these last two will be a little bit shorter than the first one, but really diving into how we can apply these to neurological fields. And so this section is really largely from a project that is funded by UCB, which is a Belgian pharmaceutical company. And so I'll touch on that and have to keep sort of one slide, the gene name back until we have sort of permission to disclose that. And so one of the first things that we wanted to do within epilepsy is to actually predict when patients would be medically resistant. As a really sort of silly toy example, and I say silly because I would never recommend that you actually use an ICD code as an endpoint for a prediction task, but we wanted to sort of do this as a initial analysis to understand the feasibility and understand what things look like. And I'll explain why ICD codes are such poor endpoints for something like this in a second. And I think the example will help to show that. So when we did this using only diagnoses, procedures, and medications data in the year leading up to an epilepsy diagnosis, we found that with a variety of different models, you could throw a random forest on here. You see a reasonable amount of predictive accuracy. This is something that was a major red flag to us because if you talk to clinicians, they would say this is a hard problem. We can't tell which patients have a seizure and are going to first have a second seizure and sort of recur, but also be medically resistant. It's a hard problem, and it's not something that we can currently do easily. And so this is a very weird result. And oftentimes when we're doing exercises like this, when you see something that seems too good to be true, it likely is. And so in this example, and I apologize, this figure is a little bit blurry, but what we found is that if you look at the time from the initial epilepsy diagnosis to the intractable or sort of refractory medically resistant, these are all sort of terms that are used in different areas to describe the same idea. Many of these patients are transitioning from a normal epilepsy diagnosis to an intractable diagnosis far quicker than we would expect. And if you look at sort of the clinical guidelines for this, they require previously 3 anti-seizure drug regimen failures. More recently, we're starting to think 2 may be enough to sort of have a good idea. And some of that comes from changes in clinical practice where the 2 drug regimens are going to be sort of separate classes of drugs and far enough apart that it gives us a little bit more information in that. And so this would still take a matter of months to separate. So when we see these patients who are immediately transitioning, that's sort of strange. And so if we just require a 6-month window between the initial diagnosis and the refractory diagnosis and filter out all the patients who transition faster, we essentially do slightly better than random. And this is sort of what we would have expected to see from the start. And so this idea and sort of our explanation for what's going on here is that even just in this one example, you can see this for a variety of appropriateness criteria for different procedures and medications and things like that, where if you have a new onset seizure, something may not be appropriate. But if you have your epilepsy categorized as medically refractory, all of a sudden it is appropriate. So what we suspect is happening here is that physicians are ordering a procedure or sort of taking some action that they believe is necessary to care for the patient. And then the back office is saying, now how do we reimburse this? And potentially using a code like an intractable epilepsy to get the claim actually reimbursed by insurance. And so for us to actually look at refractory epilepsy, we need to start to build a set of rules to actually follow the clinical guidelines. And so we did this with a couple of neurologists at the Brigham, Paige Pinnell, who's now actually at Pitt, and Risa Villamar, who's now actually at Brown. So neither of them are currently at the Brigham, but have since moved on. So in this, it was a sort of fairly intensive process to essentially figure out the reasons why somebody would transition from one drug to the next, and to establish a set of rules that could work from this to figure out when people were when a particular drug regimen was failing for a particular person, and to understand whether that was due to tolerability of the drug or lack of efficacy. And so we could then use this in all of these next analyses. And so I'll sort of touch on what we do with this. So we could start out with a set of administrative claims data. In this case, it's a fairly large set that have seizures. We can do dimensionality reduction and clustering in a variety of different ways. We use an approach called consensus clustering, where essentially you could think of it like a sensitivity analysis, where we're doing things many different ways and asking what consistently emerges. So that it's not sort of an artifact of methodology that's actually emerging. From here, we then actually choose some of the interesting subgroups that we find in the administrative claims and map these and find the population that would be in that particular subgroup in the EMR, where now we can start to do things like looking at clinical associations for lab values or different results of imaging and EEG reports, as well as very underpowered and somewhat preliminary genetic associations and things like that. And in some cases, we can leverage different registries and tools to then look at this in greater detail. So one thing that's been really valuable to us has been the Undiagnosed Disease Network, where we can look at some of these extreme cases that can help to actually explain some of the biology that's happening. And so we can start to look at some of these subgroups, and I'll sort of give just a couple, and I almost sort of hesitate to show these plots with pretty pictures where you can sort of come up with explanations as you go. And it's one thing that we want to be very careful of, that we are sort of learning the representation in one place and then validating in another. So we already have some form of secondary validation, but now diving deeper to really understand what it means to be part of a subpopulation. And so we chose one that is almost sort of a control, a positive control in those that have had brain tumors, where we could actually look at the subgroup and ask the question of, can we predict whether resective epilepsy surgery will work in this particular population? And so this problem in general is one that is quite hard. If you ask clinicians to tell you whether resective epilepsy surgery in general population will be successful, you see a range of AUCs, but oftentimes sort of centered around 0.5, and you can see it even looks somewhat balanced across the different studies. So the sort of higher performing ones may simply be by chance. And so what we did was to work with a group at Cincinnati Children's, in particular an MD PhD student there, Ben Whistle, who had sort of impressively already deployed a model at Cincinnati Children's to try to predict when patients would get resective epilepsy surgery. And now we started to predict whether that surgery would be successful or not. And so one of the things that we found is that in this particular subgroup, despite the fact that overall this is a very hard task, in this subgroup and in a couple of others, performance was really strong at both Cincinnati Children's, and then we could actually bring it over to Boston Children's to validate and to see that performance actually transferred between the two institutions. And so now we're at the point where we're working on, for limited subgroups, figuring out how to deploy this as a clinical decision support tool, obviously keeping sort of the prior section in mind as we think about that. But the other thing that we can do is to start to try to use these subgroups to understand biology. And so in one case, we found a subpopulation with a phenotype that resembled a known rare epilepsy syndrome that is very hard to recruit patients to. If you look in sort of the literature, the biggest cohorts are about 30 patients. And so when we looked at this in Boston Children's, we could see that first, of all of the patients who have seizures, only 0.1% have a reference to this particular gene in any of their notes. In sort of the population that we identify, intentionally trying to be more sensitive than specific, because we're okay with recruiting a few more patients and genotyping them. There's not too much of a cost there, and it's so hard to recruit patients here that we kept it to be a somewhat broader definition. We see about 100-fold enrichment using sort of just looking at this particular cluster that was originally extracted from claims data. We can then see that even with this sort of approach, that the vast majority of patients who ever have mentions of this gene actually fall into our match roles. And so this is something that to us was really interesting. We've looked at it in sort of the underpowered sort of population that already have genotypes and see that this is consistent. And so now we're working with UCB to put in practice, and we already really have the technology side of this developed. It's just a matter of the regulatory and commercial side with Boston Children's to actually be able to reconsent and recruit patients initially for biomarker association, but eventually for a candidate gene therapy that they actually have ready to go that could help this particular population. And so with that, I'll transition into the last section and try to be relatively brief here as we talk about the ways that we can use real-world data and these approaches to actually support clinical trials. And so a key problem in Parkinson's clinical trials is that by the time we have a diagnosis, there's already a substantial amount of damage done to the neurons in the substantia nigra. This is a figure that is, I think this is taken from the 1991 paper. It's not a new idea that we sort of see this loss prior to symptom onset. And so this project in different parts was supported by Sanofi, but was done in collaboration with a PI and really a clinical mentor to me Clement Scherzer, as well as collaborators William-Jones and Scott Lipnick. And so not only is there this problem that patients have a long time where sort of they're pre-Parkinson's, but are seeing damage to neurons, there's also a lapse between the actual diagnosis and when patients are enrolled to clinical trials. And so there's a further delay where if we sort of look back at this figure, you can imagine there's continued neuronal loss during this time period. And so it's important to try to move patients from a diagnosis into a clinical trial where we have a investigational intervention as fast as possible. And so we wanted to predict PD onset in a way that was actually useful for this type of exercise. And the reason that I sort of highlight the actually useful part is that there have been a huge number of papers in the literature that predict things like PD onset or Alzheimer's onset and things like that. But there are challenges with it in that, there are challenges with it in that PD fortunately has a relatively low prevalence in adults over 40. And so it's very easy to essentially pick cases that are very clear and controls that are very clearly controls and healthy to separate. And when you do this, you can artificially make your model look better than it is. When in reality, we know that patients follow a path and a trajectory to a diagnosis of Parkinson's. And it's not always one that's a straight line, and you may see sort of periods where they look like they're closer or not. And so this is an important thing to observe, because if you look at predicting PD onset and sort of look at periods prior to the initial PD diagnosis in both claims and EHR data, and using both deep learning and logistic regression approaches, you see that about a year out, you start to see this steep increase in performance. And so we really see this as a issue if you're trying to choose patients that have PD, match them to controls that don't, because you have to choose an index date, and that choosing that index date can be incredibly challenging and really important. And then your prediction has to be prior to some of the potential biases that can be introduced. And so in this case, what it looks like is that there's a prodromal phase of Parkinson's, followed by a period of about a year where patients may be in a differential diagnosis period where they may have a primary care doctor who suspects that they have Parkinson's, but isn't going to give them a Parkinson's diagnosis until they see a movement disorder specialist, and that could take a while. And so because of that, there's indication, and the prediction becomes easier because the clinician sort of already sees it. And so what we really need to do is to observe a particular event and then treat it as if it's a cohort, and predict for all patients who have that event observed. And so to do this, we looked at a variety of different conditions that have been associated with Parkinson's in the past, things like gait and tremor disorders, but also constipation, as well as, again, sort of a negative control here in terms of breast cancer testing. And so in each of the first three, you can see the rise prior to a Parkinson's diagnosis. But for gait and tremor especially, you can see this sometimes an enrichment far before, as many as 5 years before a Parkinson's diagnosis. And so what we did was to ask, could we predict at the first gait or tremor disorder diagnosis whether somebody will go on to develop Parkinson's? And it turns out that these models can do pretty well at this, whether or not we use complicated deep learning methods or relatively simple logistic regression methods. And this is important because in some cases we're doing this only from claims data. We actually see better performance there, but I think I attribute that mostly to the cohort size difference between the two data sets. And what this means is that at this gait or tremor disorder, we may be able to put somebody into a pre-screening study where they can have their genotype performed and other biomarker tests done before their PD diagnosis to make sure that they're actually eligible for their trial, so that if they do have a PD diagnosis, they can sort of be enrolled right away and potentially save almost a year, depending on sort of what we decide is an acceptable false positive rate for these patients. And so I'll just touch on one last section here, which is if we sort of transition now from PD diagnosis to characterizing progression, which is really important as we think about setting endpoints for trials and trying to see if an intervention is actually working, one thing we see in Parkinson's is that there's a lot of heterogeneity in the way that it actually progresses. And so this was again, you can tell this is not a figure that we ever planned to put in a publication. And so I sort of kept it like this, that to show that it's a toy example where if we just split patients based off of whether they start levodopa, so the most common and sort of really the only shown proven Parkinson's treatment, we can see that patients have differing rates of cognitive decline. And so there's never been an indication that levodopa causes faster cognitive decline or anything like that, but instead this group is getting levodopa earlier because they're having faster progression. So they're initiating therapy earlier. And so this is really just to demonstrate that we see heterogeneity here, and we wanted to try to characterize it so that we could understand how to plan clinical trials. And so to do this, we looked at 4 different data sets. These are very distinct data sets in that this is a actively recruited longitudinal cohort study. And you can tell from sort of the age of onset here being very young, that it resembles a clinical trial population in a lot of ways. Compared to 2 passively collected data sets, both EMR data from Mass General Brigham, as well as nationwide claims data from Optum, we see the more regular real-world evidence or real-world data onset of Parkinson's, followed by one that is a patient-driven, actively recruited data set where patients are actually inputting the data, which may lead to even an earlier age of onset present in the data set. And we believe that's probably because the patient is putting when they first started having symptoms. But there may be a bias there that's leading to that being even earlier than the longitudinal cohort study. But these differences end up being really big. And if you use the wrong data source for the wrong question, you could end up with an answer that's far different than what you necessarily want. And so one example of this is if we just look at the time until APD therapeutic is initiated, so including levodopa and dopamine agonists, you'll see that the Mass General Brigham and nationwide claims data are relatively consistent for the first several years. The actively recruited HBS study is much faster, but the patient-initiated data is, or the patient provided data assumes that almost 90% have a PD therapeutic started on day 0. So we're seeing a very different answer from the patients than we do from the physicians in this case. Some of this may be attributed to the fact that levodopa is sometimes given to confirm a Parkinson's diagnosis, but it would just be a sort of very short-term dose. Otherwise, there are various supplements and other things that a physician may recommend a patient take, and so they may be considering that to be therapeutic. Additionally, if we look at conditions like a cognitive decline, we see somewhat similar curves, and I don't want to sort of dive into the analysis of this too much, that's working its way into the paper, but we see that these are fairly similar for something that is directly relevant to neurology and potentially movement disorders. But if we look at something that is further away, where if you have a fracture or fall, you may go to whichever emergency department is closest. We see a huge difference between the specialist major referral center in Mass General Brigham and nationwide Optum data. And so what we think we're seeing here is that patients who may come to the movement disorders clinic at Mass General Brigham, come down from Maine or something like that, are not being captured here for something like a fracture or fall. So we need to be really careful in these things that are less relevant to a movement disorders clinic or something like that, where they would be captured in a nationwide claims data set. And so the real point of these types of analyses is to say we really need to be careful and use the right tool for the job, or to look at things across different data modalities to really learn anything insightful. And so one last thing here that I'll show is that once we have these different data sets and things like the Harvard biomarker study that has clinical rating scores like the 1NER score kept as structured data, we can do some really interesting things. So whether it's 1NER or things like the mini mental state exam or UPDRS, all these are clinical scores to measure Parkinson's progression. We can actually extract these using natural language processing. It's not perfect, but the extraction is validated, and we can do manual chart review to validate that. The challenge actually comes in the fact that sometimes notes are copy and pasted. So you may have a wrong date associated to a particular clinical rating score. We've tried to develop logic to fix that. but as you'll see here, it's not perfect. And so what we can actually do once we have these extracted is to compare, in this case, I'll just sort of hone in on the box here. We can compare the Harvard biomarker study, where if a patient has a 1-ER score of 2, where are they expected to be 12 months from now? So when you're planning a clinical trial and want to choose an endpoint, you really need to be thinking about how many patients will transition in 12 months in the control group, so that you could actually see an effect size that was meaningful in the interventional group. You'll see here that there's some improvement in the Master Brigham group. This improvement from 2 to 1 may actually be real and might happen. Where we really would doubt it is if you look at patients who have a 4 or 5 1-ER score and are going back to 2. That's where we really think there are some copy and paste issues. But again, we can compare it to the sort of gold standard here to see where those differences arise. And finally, what we can do with this is actually start to tie real-world clinical events to clinical scores to really understand what slowing progression in terms of 1-ER actually means for a patient, both in terms of quality of life, but also potential value of a therapeutic. And so we can look at things such as treatment initiation as we progress according to 1-ER, but also healthcare utilization and whether patients are having to be sent to long-term care or can go home and are still self-sufficient. And last, again, to sort of highlight one of the things that we see rising rates of as Parkinson's progresses, we can see sort of a steady increase in the annualized likelihood of fractures and falls. And so in summary, I am very intrigued by this idea that the phenotypic heterogeneity can tell us a lot about biology and trying to use this for biological discovery. But we need to acknowledge that real-world data are not generated for research. At best, it's a sort of tertiary priority. So we need to be very careful in the way that we use these data and to work with experts to integrate and to actually drive robust results. And finally, I'm especially interested in neurology, given the complex phenotypes, the difficulty in actually measuring things within the brain historically, but now seeing a rapid rise in technology and sort of data that will be available for informatics-based approaches. And so with that, I'd like to thank you all for listening and for giving me the opportunity to speak today. And I'd be happy to answer any questions in the last few minutes.
Yeah, so if you have a question, I see Taylor's hand up. You can go ahead and jump in.
Great, thanks. Thank you for the talk. I think it was really wonderful. It was a nice combination of some really beautiful data analysis techniques, and then the application seemed interesting and clinically relevant. I'm curious, with each of the different case studies you presented, it seemed like a lot of the things that you did, either the methods that you used or like the data cleaning or aggregation techniques were very specific, both to the clinical application and to the data sets that you were using. Are there any sort of either high-level methods or I guess like lessons from the applications that you think could be broadly applied across different diseases, or do you think it's always going to be a very specific process depending on the disease and the data set that's being used?
Yeah, that's a good question. So I think in thinking about that, it sort of depends, right? So the approaches to clustering, I think, can be applied to any condition that presents in a heterogeneous fashion and or presents or progresses. But the other things that will replicate are, one thing we think is really important is to learn clusters or representations in one data set to actually validate it in the second data set where you have some additional data element that was not used to learn the clustering, because that can help you to validate. And so that's where the lab values and things like genotypes become really useful. So as much as I would like to include biological data in actually learning the clusters, then you end up with this challenge of how do you validate that what you learned is interesting, because you're sort of course, they're going to separate if the biology are actually different into the ways that things would separate from a data perspective. And you don't know if there's actually a meaningful separation there. The other thing to us that has been really helpful in a way to start thinking about things is to almost always perform sensitivity analyses and using approaches like I mentioned with consensus clustering, where we can cluster 50 different ways and ask sort of, does 95% of this cluster emerge in 45 of the different methods? If we see that, all of a sudden it's a lot more interesting and something that's worth pursuing and less likely to be sort of an artifact of hyperparameter decisions or anything like that. I think that particularly in the unsupervised world, hyperparameter decisions and you can't sort of do parameter sweeps because you're essentially p-hacking unintentionally by doing that in multiple testing. So you need to be, I think, smart in the way that you design that experiment.
Any other questions? I think we have time for probably one more before the top of the hour.
Sure. So really great talk. Totally agree on like every point you made. As you got to that last little example that you had of the different data types, you had highlighted one key demographic difference between these individuals in terms of their age of onset. But I'm curious whether you looked at sort of other demographic relationships in these different data sets and how that relates to, you know, your coverage of the epidemiology of these different traits that you're looking at, to sort of get a sense of both this data availability question as we think about, you know, yeah, they're not going to show up with a broken leg to their specialist, but also then how representative each of these data sources are.
Yeah, so we've started to, and we know some of the shortcomings of sort of the Mass General Brigham population, just as a whole, knowing that on average it's sort of socioeconomically better off. There's a higher percentage with commercial insurance. There's enrichments for certain genetic forms of Parkinson's, for example, GBA PD, where it's more prevalent in the Ashkenazi Jewish population. So we know there's an enrichment in Mass General Brigham for things like that. So for genetic forms of PD. But I wouldn't say that we have sort of conclusively been able to do that in some of the other data sources, partially because of some of the things like ethnicity data and things like that being either lacking or weak in different data sources. And we've all seen this, I think, in some of the examples where people have done a comparison between patient self-reported information and genetic analyses where they don't always correlate as strongly as you think they would. So I would love to do more of that. I think the other area where we have done that, and I don't present it too strongly yet, was in the example where we were looking at model divergence for predictions. We saw some of the important predictions were things like whether the patient spoke English or not. We aren't at the point yet where we can make sort of strong enough of claims there to sort of include it into the main talk, but it's something that we're definitely investigating to try to figure out why that could be a significant difference between the two populations when it's not used in sort of the model training or prediction, but the fact that the two groups, so the patients that the two models diverge more commonly don't speak English is a strange finding, and so it may be spurious. We need to sort of figure out more robust ways to validate that, but that's sort of a preliminary finding that we definitely want to dive deeper into.
Awesome, thanks.
Okay, so we're right at the hour. Thanks, Brett, for a really great talk. I think likely people are having to jump off. I know I have to jump off, but if anyone would like to stay on, I'm not sure. Do you have a meeting right after this?
No, I have time. I think of a break.
Okay, so I think if there is any additional conversations, feel free to hop on, but we'll formally close this out for now. And thanks everyone for attending today.
I just had a quick question.
Sure.
It was really good work, and so I'm new to machine learning per se, and so I guess the rationale for choosing like logistic regression or trying a different model, like have you tried other models that might be better or not? Where do you draw the line of like logistic regression is sufficient and we're moving on, or spending more time on trying these other algorithms? What's your general thought on that, I guess?
Yeah, that's a great question. I think in that initial setup, you can sort of relatively simply ask logistic regression some ensemble tree-based method. And if you see a difference there, then maybe it's worth looking at deep learning approaches that may learn from other things like sequence or sort of having something that's like a recurrent neural network or something like that. But if you don't see a difference between, and this is again in some ways still more art than science, if you don't see a difference between some of the logistic regression and tree-based ensemble methods, which can obviously be more sophisticated than a random forest, you can start talking about things like XGBoost and things like that. There's not, I think, tons to be gained by sort of iterating on more complicated methods and or doing huge parameter sweeps, other than sort of the point that I think I made a little bit before, that you may sort of get lucky with some split of the data or something like that, where you end up making a spurious finding or association. So you need to be a little bit careful if you sort of just test every parameter under the sun. One set may sort of luckily lead you to an answer that is not going to be robust or generalized.
Cool. Thank you.